Welcome and thank you for joining us. This is Snapshot session 1 and my name is Janelle Hannon. I will be your moderator for this session. So before I introduce our speakers, we just want to start the session with a couple of reminders. Like was mentioned before, you can increase the size of the slide presentation by right-clicking on the presentation image and selecting Picture-in-Picture and resizing the pop-out window. And this is a snapshot session, meaning that we have 3 presentations and all of them in the theme of partnerships in care. So after each presentation, I'm going to spend about a minute or 2 on any questions that come up in the chat, and then we'll move on to the next presentation. After all the presentations have been completed, we'll have a bit of a discussion period with all of the presenters. And at that time, you can ask any questions that may have come up using your microphone, just simply by raising your hand. Okay, and if there's no questions about that, I will now introduce our first set of presenters for the session. So first we have Connie Foster, who is a nurse practitioner manager / primary care provider at Moose Deer Point First Nation, and a mental health and addiction clinical team lead for the West Parry Sound Health Center / rural nurse practitioner-led clinic, also known as WPSHC / NPLC. As well, she is the co-lead of the Rapid Access Addiction Medicine team in Parry Sound, Ontario. Connie provides on-call and inpatient addiction medicine consults to the WPSHC hospitalist and emergency physicians. She is the WPSHC Indigenous lead and a registered band member of the Suganaqueb First Nation. Connie is a strong advocate and ally for people who use substances, and she participates in collaborative regional and provincial initiatives to strengthen and better support health integration and best practices for people who are at higher risk for stigma, racism, and poorer health outcomes. Secondly, we have Irene Boldt, who's a registered nurse with a clinical and research background in forensic mental health. She has a certification in psychiatric and mental health nursing, as well as a PhD in nursing science and bioethics from the University of Toronto. Her research interests include qualitative methodologies, critical ethics, particularly in social justice, and community reintegration and recovery within the forensic mental health system. She worked for almost 10 years at CAMH in Toronto as a point of care clinician, an advanced practice clinical leader, and a doctoral research fellow. Irene is currently a clinical lead and nurse navigator responsible for the Safe Justice Bed Initiative at the West Parry Sound Health Center. Connie and Irene will be presenting the West Parry Sound Health Center Mental Health Hub, an integrated care approach to addressing substance use in the Parry Sound region.
Hello, everybody. I'm Irene, and you can see my colleague Connie here as well on stage with me. Janelle, thank you very much for that introduction. So today we are going to be speaking with you our presentation titled The West Parry Sound Healthcare Center Rural Nurse Practitioner-Led Clinic Health Hub, an integrated care approach to addressing substance use and mental health issues in the Parry Sound region. As you are aware, Connie is one presenter and I am the other, and we have nothing to disclose in the context of this presentation. The objectives of this presentation: by the end of today, you will have an understanding of the unique challenges and approaches to addressing mental health and addictions issues that we face here in our Parry Sound community and the surrounding region. You will have an understanding of how the RAAM model evolved in the Parry Sound community from 2019 until now. You will have an understanding of how the Mental Health Hub was created and how it functions as an integrated wraparound approach to care for people with mental health and addictions issues that focuses on partnering and relationship building within the community to meet the demands of the care needs of the people that we are serving. And also we want to talk today about the impact of stigma and racism and how they are being addressed through the integration of policy here at the West Parry Sound Healthcare Center. Connie?
Thank you, Irene. So I'm going to discuss the development of the RAAM clinic model, bringing forward the challenges and identifying the approaches that we took tackling mental health and addictions in the Parry Sound and surrounding region, while taking into consideration the land base and all the barriers that go along with delivering a regional service. Next slide. The land base is important to understand as healthcare delivery and approaches need to be tailored differently when comparing rural versus urban, and to consider the population and the culture of that population that reside in the area. Parry Sound and the surrounding area is composed of the town of Parry Sound with a rural surrounding region located on the eastern shore of Georgian Bay. Parry Sound is approximately 160 kilometers south of Sudbury and 225 kilometers north of Toronto, and the region expands just south of Sudbury and over to North Bay to the northern border of Muskoka. The healthcare services for this region extend over 6,000 square kilometers and include a semi-rural to rural landscape. 78% of the population live in the rural area. The region is home to 6 First Nation communities, and you can see this with the circles on the second map. In consideration to Indigenous history and land base, you can visibly see the tactic from the history of colonization. Land base was a way to isolate and control First Nation people on reserves, and today poses many barriers for access to care, federal services versus provincial services, and having to navigate between one of the highest populations facing mental health and addictions. We are also recognizing that multiculturalism is increasing in Parry Sound. The region population in 2016 was estimated at approximately 34,000 and increases by 300% in the summer, with the influx of residential cottagers, vacationers, and includes residents also from the United States who seasonally reside on the 30,000 islands on Georgian Bay. And as a collective, they do access our healthcare services, including services for mental health and addictions, and when they're in crisis. Next slide. The Parry Sound RAAM is a model stemming off of the services of the West Parry Sound Health Center and the rural nurse practitioner-led clinic. We are a unique model in the sense that we are a hospital with attached primary care delivered through 6 regional nurse practitioner-led clinic sites, strategically placed throughout our region in partnership with the local communities each site serves. RAAM is situated within the bricks and mortar of the West Parry Sound Health Center. In 2019, we were approached by CMHA, Muskoka Parry Sound, who had been awarded the RAAM funding and were unable to find a physician to support the program. So I'm a primary care provider, and I operate one of the 6 nurse practitioner-led clinic sites. With my background also in addiction medicine and acute withdrawal management, I offered to assist in seeing patients through this partnership model developed with CMHA and the West Parry Sound Health Center. I trained other providers interested in addiction medicine. We had to act and consider the local concern of lack of services for the growing mental health and addiction crisis, so access to services otherwise was outside our region. Next slide. We launched the RAAM partnership in May 2019. The NPLC offered in-kind services of 2 NPs and a secretary and a social worker in partnership with CMHA, who provided the addiction counseling. The NPs also offered the addiction medicine consult team program 24/7 to assist the hospitalists and emergency physicians with opioid medicine treatment and education. So now the MDs, the emerged doctors, are now starting OAT therapy in the ER and now understand the need to admit patients in hospital for severe alcohol use disorder. We also see clients in the hospital and assist with the challenges and treatment recommendations. So currently RAAM services are offered 2 days a week, and that's been all along. This is all the capacity that we have, and it does bleed into our primary care practices with the other nurse practitioner, Teresa Westlar. We share that co-lead practice. We eventually received a RAAM stipend fee and funding for a departmental lead. We also had to navigate around the challenges COVID posed in our region, especially considering our isolated First Nation community who were often under quarantine and needing access to methadone and Suboxone. We worked on delivery service challenges, partnering with our local pharmacies and the OATC partners. In 2019, the Parry Sound Drug Strategy was launched through the North Bay and Regional Health Unit, and I took on the role as co-lead and committee member to advocate and work on education and advocating about the crisis and initiatives within our region. So we're essentially operating on a skin and bones service and being creative with our partnering organizations and working off the side of our desks for the past 4 years. With in-kind services and scarce funding, however, we continue to grow an essential service. Irene will discuss the creation of our West Parry Sound Health Center Mental Health Hub and partnering organizations that we designed to enhance and fill the detrimental gaps in our region. Thank you.
Thank you very much, Connie. So Connie has given a really great overview of how we arrived at the opportunities that we are currently working on in our community to create a health hub that, as Connie rightly has identified, is bricks and mortar housed within the West Parry Sound Healthcare Center. And we have worked to create a wraparound approach to care for people in our region with mental health and addictions issues. And we have really worked, and Connie has clearly spoken to how we have fostered relationship building and partnering with community organizations to develop care pathways that are more streamlined for people in our community who have mental health and addictions needs. So we have created this health hub, and as I've said, it exists within the health center here, the West Parry Sound Healthcare Center. And so Connie has rightly pointed out that we have a RAAM clinic here that is led by nurse practitioners, and that clinic is currently run 2 days a week out of the health hub. We also have an orphan clinic, which is also led by nurse practitioners in our community who come into the West Parry Sound Healthcare Center to provide primary care services for people who are otherwise marginalized and unable to access those services in our communities for some of the reasons that Connie outlined previously. We also have an OTN suite within the health hub, which means that we can coordinate with psychiatry, which we do not have in our region, but we can support our clients' needs and their interactions with psychiatry using the OTN suite. We also can connect them with other specialists as needed from the health hub, which is fantastic. We also have a safe bed in the health hub, which is run by a registered nurse, me in this particular context. And that bed is an inpatient short-term 30-day stay opportunity for a person with mental health and or addictions issues and substance use issues, and it's an opportunity for them to really reintegrate and plug into their care and get the benefits of the integrated care pathways we've created in this community. We also offer inpatient mental health care. So if people come into hospital with medical issues, they can get support and care for their mental health and addictions needs, and that's provided by a registered social worker and a registered nurse here in the hospital. And that same registered nurse and social worker also provides system navigation for people who come into hospital and have mental health and or addictions care needs that extend beyond the stay that they might have in an acute care hospital setting. So that's how we have integrated and created care pathways within the context of the healthcare system here in Parry Sound so that we can meet the needs of the people who live in our region. And this is just a photograph of what we have been able to accomplish, because when I started in this role 16 months ago, we did not even have the bricks and mortar space to support the kinds of initiatives that we have been working very hard and are continuing to work on. And so I just wanted to share with you the sense of what this physical space looks like. And as I said, we have one nurse, one registered social worker, a mental health and addictions worker who is also a collaborative employee with our District of Social Services. We have 3 nurse practitioners, of which Connie is one, and we have one admin person who helps us hold this whole thing together. And now I'm going to let Connie speak to the next important issue, which is, despite the integration of care, stigma and racism continue to be huge barriers to providing the care that we are striving to in this community.
Thank you, Irene. So stigma is one of the greatest barriers faced globally for those with mental health and addictions seeking healthcare services, followed by racism and discrimination. Also add on colonization and multiculturalism. It is a perfect storm contributing to poor health outcomes, overdose, and early death. So advocacy and leadership are part of our roles as healthcare providers, and who best to pony up, so to speak, become creative and advocate at various levels of government to policymakers to our funders, create policies within our organizations, and speak at rallies, be the voice for the most vulnerable. We know the gaps firsthand as we are bearing witness to this every day. In the work capacity, this poses an issue. We're already stretched to the limit. One idea that we have brought forward is policy development. The West Parry Sound Health Centre will be the first organization to launch the crystal clear Code of Conduct, anti-stigma, anti-racist policy organizational-wide. Next slide. This policy is spearheaded with the spirit and pledged support of the First Nation communities and organizations in our local area. I presented the idea of this policy with signed pledged support from the local Indigenous communities to the West Parry Sound Health Centre leadership, and it was approved to move forward. A working group was developed with human resources and was Indigenous and community-led. Thus, Chief Nursing Officer Katie Hogue, who is also a nurse practitioner, states, "We are taking this seriously as an organization." This policy was developed to address any complaints or concerns of stigma and racism for the care received and delivered under the umbrella of the West Parry Sound Health Centre, including the 6 nurse practitioner-led clinics, starting right at the board level, includes staff-to-staff complaints, patients, and for patients, clients, families of the loved ones who are receiving that care. It lays out a reporting system to address an informal to formal process that could lead to termination of a position. It is rooted in education and includes recommendations for cultural safety, continued education ongoing, and it includes all for staff and board members as well. The policy is in alignment with the Ontario Health Indicators to address access, inclusivity, diversity, equity, and racism. It is a way to operationalize the indicators that need to be reported back to Ontario Health. We are hoping to develop a toolkit for any organization that would like to adopt this policy. This policy was initiated on behalf of my daughter, Crystal Gracie, who was a Suganaqueb First Nation band member. She accessed healthcare throughout Toronto, Simcoe, Muskoka, and Parry Sound region. She was diagnosed with a rare blood disorder, hereditary angioedema, and sarcoidosis at the age of 27. This disorder caused widespread body flare-ups and pain and was managed by hydromorph. Because of the strong pain component, which we all know what that looks like, and identifying as Indigenous through self-identification, she experienced various levels of stigma and racism, and I witnessed this firsthand. Unfortunately, my daughter passed away and went off to the spirit world March 25th of last year. So in my daughter's memory, it will be crystal clear of the expected behavior must be stigma-free and racist-free for anyone accessing and delivering healthcare under the umbrella of the West Parry Sound Health Centre. Next slide.
Thank you very much, Connie. In conclusion, I hope that the takeaway message from your listening to our presentation is that while we recognize the value of an integrated approach to care and are working very hard to create that in our community, we also want to highlight that stigma and racism continue to be barriers to care. And as frontline clinicians and people who are able to apprehend the problems, we have a responsibility to step up and do something. Connie?
As addiction and mental health clinicians and leaders, we are in a position that is so critical as frontline providers delivering services in the worst epidemic. With one of the least resources, the need to be and to have safe and equitable services. We need to shout out about this crisis because death is the consequence. We must strongly consider our roles as leaders and advocates. We need to make waves to ensure the creation of services and clinical care pathways are improved and save lives better. One idea, one voice can be infectious in a good way. We know this to be true because we have changed how healthcare is delivered in the Parry Sound and surrounding region. There is still much more work to be done to save lives. And on a last note, we're offering RAAM services starting next month, going from 2 days a week to 4 days a week without an increase in significant funding, unfortunately. Thank you, and miigwech, for attending our session.
I don't see any questions in the chat at this time, so we can move on to our next presenters and see if anything comes up at the discussion portion of things. So I'll invite Ruben and Maria to get on stage and set up their presentation now. So our next presenters will be speaking about the healing journey, a qualitative study on recovery from opioid use in a remote community. First, I will be introducing Maria Suganaqueb, who is a coordinator of the opioid substitution therapy program and the I apologize. Webequie, thank you. Webequie First Nations. In this role, she is active in coordinating research to ensure that she and her colleagues can provide the best care possible to their clients. The research focuses on enhancing the quality of opioid substitution therapy and embedding therapy in a culturally appropriate, community-driven context. We also have Ruben Hummelen, who provides acute and primary care in fly-in communities in Northwest Ontario. He's had the privilege of being the community physician for Qualitative First Nation since 2017. As a team, they strive to provide care in a culturally appropriate way and take direction from community members and leadership on how to provide care through their program. The subject they're presenting aims to provide knowledge on how to optimize care for the clients that they serve. And as a primary care researcher, Ruben is involved in quality improvement throughout Northwestern Ontario. His research focuses on maternal child health and improving standards of care for opioid substitution therapy in Indigenous communities. So without further ado, Maria and Ruben.
Wonderful, thank you so much, Janelle. So I'll first invite Maria to speak on where Webequie is.
Hi, Webequie is located for up to close to James Bay area. It's about 500 kilometers to Thunder Bay. And Webequie is a fly-in community. We have access to Winter Road, and we have probably about close to 900 population.
Great, thank you. And then about our team.
We have 2 workers that are DOT, and we work with we work close by with the clinic staff here, along with a doctor, and we have 2 to 3 nurses that come in every 2 weeks. They come in and out. We have 2 nurses, nurse in charge, 2 nurse in charge, and sorry, I'm kind of nervous.
Perfect, that's a great description. And then not in this picture, but Dr. Jennifer Wyman, our chair of today. She is the addiction physician visiting every 3 to 4 months. So just a bit of context about opioid substitution therapy in the community we serve. It has really become available since 2012. It really is initially only Suboxone, and now in the last months to 2 years, Sublocade. The program is administered by the Band Council, so Maria is and her staff are paid through the band. Clients in the program, of which we have about 130, they do see a physician ideally every 3 to 6 months, but sometimes that can lengthen out to every 12 months, depending on physician availability. There's quite limited counseling options available. yeah, the program comes with lots of challenges and opportunities. The demography is quite unique. So in the region, about 14% of the adult population receives OST. So it's much more of a public health focus and a community focus than an individual focus. Typically, people enter a program younger. Also, the sense of instability in urban areas versus a community like these is very different. Yeah, it's very much a community. The community is aware of what happens in the program. The community has a particular wishes to have the community wishes the program to have a particular direction. We have limited human resources, unlimited natural resources. The land is very important for people and also for healing. And then community resources in terms of land-based activities, ceremonies, etc. Yeah, so there's no literature on what it means to be on OST in a remote community and what it means to heal from opioid use disorder in such a setting. So Maria and her staff, supported through the First Nations Health Authority, set out to do a qualitative project interviewing 16 people on the program to see what was helpful for them in recovery and what was a barrier. So we first started to ask people how it all started, and this is a quote Maria will read.
How it started, I just needed somebody to talk to or somebody to listen. Then finally I had enough, couldn't cope with my feelings. I couldn't deal with what I was going through, so I went to my friends, and that's when I started using Percocets, oxycodone, and then that led to shooting up.
Yeah, so very much a story of trauma, adverse childhood events, context people grow up in, and then at some point it just not being just being enough, and then that's sort of the story many people described. Then in terms of when people came to a point where they felt they wanted to make a change, Maria?
I started to realize I needed to stop because of what I was putting my kids through.
A very, very strong theme through this making a change topic was really family, in particular children, not having enough resources to provide for children, seeing them grow up and not being able to support the way you want to. What was a huge impetus for people to look for a change. Then challenges in recovery, Maria.
Stop talking to people. I'd isolate myself from others that were using or that were talking about drugs and trying to ask me to can get this or that.
Yeah, the first stage of the healing journey where people really stay away from illicit substances is already a very isolating experience. People lose many friends, sometimes family, but then sometimes people what we call graduate from the OST program, and they out of their own desire and the community's desire, they want to move on from OST. They also describe that as a process where that can be quite isolating, and yeah, that they feel removed from the people they were close to. Then supports in recovery, Maria.
Being out on the land, the reflection of your mind, and it sort of clears your mind as well for your goal. Like it brings some kind of connection with Earth and Mother Earth, motherhood, and all that. I think that is where I got my strength from.
Yeah, what has been coming through is really the land, and being connected to the land are really important factors in healing and allowing people to venture out, and also rooting yourself back into your cultural context, ceremonies. That was a very important part of people's recovery and ongoing strength. Then opioid substitution therapy with Suboxone. The length people are on the program is now a maximum of 11 years. That's when it started, of course, but some people spent only a few years on the program. This is what someone says, Maria.
Like it was holding me back in my life. I just didn't want to be part of my life.
Yeah, so even though OST initially is a complete game changer, people can spend their money on other things than substances. People can start to live stable lives, work on their relationships, work, etc. At a certain point, it truly starts to wear on people. Clients, they do attribute certain health consequences to Suboxone, especially dental issues. Also, from the community leadership, it becomes quite clear at times that they wish this not to be an indefinite period that people spend on OST, but that the movement really needs to be toward graduating. So that is also very much a focus that is quite different working in this community. Yeah, best of now, we asked people what their experience now is while they are sort of concluding their healing journey or are still on their way. Recovery was described as a long and holistic process. And Maria, go ahead.
Recovery was described as a long and holistic progress that took me probably 2 years to really learn about the human being. My sense of taste came back, and all those emotions I didn't feel when I was on Suboxone all came out. I cried anywhere, anytime. I don't know, it's so weird, like I was learning how to be a human again.
Yeah, people describe when they come off an OST program that their emotions are much more at the surface, are uncovered, and that's is a blessing and a challenge. So people describe it repeatedly as learning to be human again. From myself as a clinician, paradigm says that on OST you are just functioning like any other human being, but the experience of these participants was quite different. That it still had sort of a numbing impact on their existence. And this is another picture of our team, this time with Dr. Wyman and a number of other staff in our team. I believe the questions are till the very end, but feel free to go ahead if you have one now. Appreciate the claps.
Did anyone just hear anything I said? I think I was muted. I was just thanking Maria and Ruben for that presentation. Not seeing any questions in the chat at this time. Oh, one just popped up. Are people able to access dental care while on OST?
So yes, there is access to dental care. There wasn't any access to any dental care during COVID. So there was about 2 years. And now it's quite limited because they're renovating the dental office. So people have to fly out. And there's a huge backlog, but there is access to especially acute dental care. We can't hear you, Janelle, I think.
Yeah, Janelle, I know that there are some tech challenges. Sorry. Try again.
Janelle, could you please reload your browser? And in the meantime, maybe I'll invite Subo and Carol to come to the stage and get your presentation ready to share.
I apologize for that, a little bit of technical difficulties on my side. I will go on to introduce our final presentation. So our final presentation is about the environmental scan of urban RAAM clinics serving Indigenous people. We have Carol Hopkins, who is the Chief Executive Officer of the Thunderbird Partnership Foundation, a division of the National Native Addictions Partnership Foundation, and is of the Lenape Nation. She holds a Master of Social Work degree from the University of Toronto and is a 4th degree Midawawin, a sacred Anishinaabe medicine society where she is a chief and teacher. Throughout her 25 years in the field of First Nations substance use and mental health, Carol has made use of Indigenous knowledge and research, policy, practice-based evidence, teaching, and education, and in facilitating processes of decolonization specific to epistemic racism. In 2018, Carol was appointed as an officer in the Order of Canada, and in 2019, she received an honorary Doctor of Law degree from Western University. We also have Subo Awan, who is a registered nurse and the executive director of Village Family Health Team. Subo has more than 13 years of experience in community healthcare, with a focus on mental health and addictions, prenatal care, primary care, and needs-based program development. Her passion is to help promote positive health outcomes for vulnerable populations, and her experience includes participating in the development and implementation of community-based programs for individuals living with serious mental health illness or substance use disorders.
Well, thank you, Janelle. All right. Okay, so thanks everybody. Good morning to you all. Like Janelle said, my name is Subo Awan, and I'm pleased to present today with Dr. Carol Hopkins. We will be presenting on the results of an environment scan conducted on Ontario Health-funded Rapid Access Addiction Medicine Clinics, or RAAM clinics. We would like to acknowledge the following people who really helped us with this project: Dr. Malkahan and Marie Corrado, Sarah Clark, and Laurie Smith. And this project was done in partnership between PHI and Thunderbird Partnership Foundation. So a little bit of a background here. So, why we decided to do this project. So there was a report issued by the Chiefs of Ontario highlighting that Indigenous people are disproportionately impacted by the opioid crisis. An increase of opioid overdoses and opioid-related deaths in recent years is largely due to the rising presence of fentanyl in the illicit drug supply. And First Nations people are at 4 times higher risk than the general population for opioid-related deaths. So there is an urgent need for us to address this issue. In Ontario, there are 70 publicly funded RAAM clinics. And even with the RAAM clinics, the overdoses related to substance use and opioid-related deaths are rising in Ontario. So RAAM clinics, they do operate with 3 core principles: accessible care, appropriate care, and integrated care. But do these core principles also include culturally relevant care for Indigenous people? A literature review had revealed that no reports on the current services provided by RAAM clinics, and there are no reports currently that we can find on what services are provided by RAAM clinics specifically for Indigenous people. But a recent review of healthcare barriers faced by Indigenous people residing in urban settings identified the following key areas: communication challenges with healthcare professionals, access to medications, that includes denial of medications to treat substance use, and lack of education that providers have in treatment options, inappropriate dismissal or discharge, including inappropriate verbal and physical behavior of healthcare providers. There's long wait times to access these services. There's mistrust in the healthcare system, racism, and also financial and transportation barriers. So despite having a higher density of healthcare resources in urban settings compared to rural areas, Indigenous people do not have better access to healthcare services or health outcomes if they reside in these urban centers compared to those who live on reserve. Our literature review also identified the following key services that could increase access to healthcare services for the Indigenous people. Having more opportunities for individuals to access their own culture, traditional healing practices, access to services that are Indigenous-led, and access to culturally safe care to promote client retention. So our objectives of the environmental scan. So this environmental scan that we just finished conducting will be preliminary information that the PHI team will be using to inform the Ministry of Health and Ontario Health of service gaps for Indigenous people, specifically accessing RAAM clinics in urban centers. The following steps were conducted to identify the RAAM clinics included in this environmental scan. We developed a project charter, and the project was approved by PHI and APQIP, which is the Assessment Projects and Quality Improvement Projects at Women's College. A list of RAAM clinics located within urban settings in Ontario, and we used census data from 2021. That list was composed, and then it was further analyzed to identify RAAM clinics located within an urban area where a higher proportion of self-identifying Indigenous individuals resided, and we used at least 5%. The top 10 RAAM clinics were identified to participate in the environmental scan. The environmental scan interview questions were co-designed by the project team at PHI and by Dr. Carol Hopkins. And the administrators and clinicians from the 10 RAAM clinics that were invited participated in a 15 to 30-minute Zoom interview with myself. And during the midpoint of the data collection process, we found it really challenging to identify concrete common themes. So we expanded the scope of the project. So we changed it to include RAAM clinics located in urban areas where at least 4% of residents self-identify as Indigenous. So in total, 15 RAAM clinics were contacted to participate in this project. All of the interviews were completed by end of March earlier this year. Here is a summary of the interview questions that we had asked. So in total, there was 7 questions. we asked questions related to the types of cultural and traditional services that were provided by the RAAM clinic. How many Indigenous people are they providing care for? What are some gaps that they have identified within their own settings? What have their clients expressed a need for? And we also wanted to get a general sense of the relationships that these RAAM clinics have with local Indigenous organizations. So what were the results of the scan? So we were able to interview 14 out of the 15 RAAM clinics that were invited. 12 of the interviews that we had conducted, in total there were 12 interviews that were conducted, and 3 of those of the RAAM clinics that we had invited, we were able to collect the information with a single interview because that one health center had operated all 3 RAAM clinics. The length of RAAM clinics, it ranged from 15 minutes to an hour and a half, and it included a diverse range of service providers. So 86% of our RAAM clinics were not collecting demographic information. They weren't asking their clients if they identified as Indigenous. All of the RAAM clinics that we interviewed have established close relationships with local Indigenous organizations. They were providing referrals for cultural and traditional services. And all of the clinics expressed interest in improving their services for their Indigenous clients through a community of practice. We did face some challenges identifying common themes for specific service gaps that were identified by the RAAM clinics due to organizational and geographic differences between each of the clinics. Some clinics had multiple sites with a central hub situated within the urban center, and the funding and staffing for each of these RAAM clinics were also incomparable. So we conducted a thematic analysis with the data collected following Clark and Braun's 6-step data analysis process. And using this process, we were able to identify 3 key areas for service improvements: basic needs, medical needs, and cultural social support. And these meta themes were derived from the results that focused on 3 out of the 7 interview questions. So the first meta theme, basic needs. So 43% of the RAAM clinics identified that their clinics required support with the following services: supporting their clients obtaining personal identification, transportations to and from appointments to see their providers, and or to support them in getting to the pharmacies to access their medications. They needed help with housing support, both short-term and long-term, support with accessing local food banks and meal programs. Many of the RAAM clinics sites were located in a central location within the urban area, which was identified as a barrier for some of the clients who were trying to access those services who live in more remote areas. Most of the RAAM clinics are the only publicly funded addictions program in their local area. 3 of the 14 RAAM clinics provided mobile services to their clients, either in the form of providing home visits or a clinic on wheels. For the meta theme, medical needs, a lack of access to some of the OAT treatment options like methadone, Suboxone, Sublocade was identified by 6 of the RAAM clinics. So barriers included lack of access to pharmacies who were willing to dispense the medications that was prescribed. There were lack of providers available that had comfort in prescribing a full range of OAT. There was also lack of physical space that some of the RAAM clinics had identified. They weren't able to administer treatments such as Sublocade. And there was also a lack of physician funding to retain physicians. Other barriers that were reported by the clinics included limited hours of operation of the RAAM clinic, limited access to primary care services to discharge stable clients, and lack of access to other harm reduction services in their area. For cultural and social support, 6 RAAM clinics identified the need for better integration of traditional services to the RAAM model. One clinic mentioned that they would like to have more a welcoming physical space that incorporated traditional and cultural decor to promote a more healing environment. 7 clinics identified stigma and racism as a barrier, mentioning that abstinence from substance use continues to be promoted in some communities, which was identified as a barrier for some clients who are trying to seek treatment. One RAAM clinic did identify that their clients have expressed a need for better support from law enforcement to address specific challenges within their local communities. And I'll hand it over to Carol to discuss the recommendations and next steps.
So 4 recommendations coming out of the study, and one is for improved data collection, but also standardization of demographic information, and 2, to improve access to supports within the RAAM services, not only for the individual, but for their families as well, in terms of basic needs that go along with the analysis and the meta themes, such as housing and food security, things like that, but also access to other resources. And then improved access to a full range of medical treatment options, including pharmacy access. So again, reflecting on the barriers to the different forms of medication prescribed and not always available at local pharmacies. And then the inclusion of Indigenous culture and traditions embedded into the RAAM services, rather than leaving it up to individuals to seek out those services on their own in different locations, but having them as part of the service environment. Next slide. Okay, and so some of the next steps are we want to advocate or to promote these recommendations with Ontario Health and Ministry of Health. And so some of those points of advocacy include support for the RAAM clinics with adequate funding to develop and implement standardized intake forms that are co-designed with Indigenous organizations. And I imagine along with that, there would be agreements around data sovereignty for First Nations and self-identifying demographics, so that the identity of Indigenous people is also supported when they experience, or if they experience, instances of stigma and racism. And funding to hire staff to support Indigenous clients to access services related to their basic needs. Transportation again was mentioned as a huge issue in accessing pharmacy, or even getting to RAAM clinics, depending on even within the urban environments, or from moving from reserve to an urban environment to access RAAM clinics. Funding to support training of all pharmacy to dispense the full range of opioid agonist therapy, and expanding the scope of practice for nurses to prescribe OAT under medical directive to increase the capacity within the RAAM model. And then funding to expand clinic space to accommodate all treatment options. And so spaces and environment has certainly been highlighted through all 3 presentations as critically important to a culturally safe environment. And then funding to support virtual services for individuals seeking support. And then promote the expansion of RAAM teams to include mobile services, again, to expand the reach to rural and remote communities, and such as what we heard in the Webekwe example. And then increase funding to support hiring physicians and nurse practitioners that can be retained in the RAAM services. And then health promotion and education campaigns are critically important to help reduce the stigma in emergency departments, but also other healthcare settings as well. And that there is a need for Indigenous peer support workers and Indigenous patient navigators. Thank you. That's our presentation. If you have any questions, we can find them in the chat, I guess.
Thank you, everybody.
Hi there. I'm Sarah Clark. I think that Janelle is having some technical. Oh no, here she is. Okay, never mind. Janelle, are you back? I can't hear you.
Question in the chat. It's Jennifer just jumping in. That was for the Webequoy team, for Ruben and Maria Cindy. Can you share more about the team and roles in the program in Webequoy, and how are the DOT staff trained and supported? I know, thanks Ruben for sharing that. Do you have a couple minutes to speak to that and how the team works together?
Yeah, sure. I'm not sure whether Maria is still available. She is, of course, the one looking after our dispensing team. But yeah, we have typically 2 dispensers, and then for the past 2 years, we've had a coordinator, and they look after the dispensing and the travel scripts and physician appointments, etc., for about 130 people. Yeah, so intermittently that's supported by a counselor, not specifically funded through that program, but just through other programs. So that's the extent of the team. Yeah, so the dispensers are only are supported really only through either what comes through the leadership, and then also by Jennifer Wyman and myself if we when we are visiting. So the support is quite limited. We would love to see more support through the pharmacy, especially, and the First Nations Health Authority is now starting to put together curriculum to train people and provide some more support as well.
I'm just going to jump in if that's okay, because it looks like there's a question from Sharon that's probably aimed more at Carol, but for anyone else.
Thank you, Ruben. There's another question of, are there any examples of good data governance agreements / processes that local urban Indigenous partners, when health data is being collected, not from one nation, but from people representing a wide number of diverse First Nation, Inuit, and Métis people?
So it's Carol. I'll just say what I said in the chat. This is a discussion that is currently taking place within PHI in partnership with the First Nations Information Governance Center and other Indigenous organizations. So there are many across the country, many Indigenous specific organizations even, who are serving urban populations, not necessarily under the governance of a First Nation or a Métis Nation or an Inuit government, and are collecting data. And so the question is, who owns that data, and who has what are the rights? So this is something similar that would fall in that line. The First Nations Information Governance Center has developed a data sovereignty framework, and you can find that on their website. But it is a conversation that is currently taking place, and I'm not sure that they've gotten to any conclusions.
Hi, this is Sarah again. Thanks very much, everybody. I see Sharon's got her hand raised. Sharon, would you like to elaborate?
Sorry, how to use this platform. Okay, hello, good morning. So actually the question that was responded to by Carol was posed by my colleague. We're here together up in a northern community. It's Claire Bodkin actually asked the question, but my platform is what we're using for the my computer is what we're using for the meeting. So I want to express gratitude for these sessions and for sharing this and making this more a part of our conversations at conferences and amongst colleagues and in our networking. And for sure want to express gratitude for Ruben for sharing about these really incredibly innovative programs that Thunderbird Partnership Foundation has supported from the very, very beginning. And it's the leadership. It was non-clinical people that brought these community programs into being. They just had an incredible literacy about what their communities needed, what their people needed. And then we came in as guests, you know, the physicians that were involved and the nurse practitioners that were involved in. And I just want to express a lot of gratitude that this is all being shared and with other communities to know about what's been going on up in Northwestern Ontario, because it's really made a difference and a huge impact in communities that to this blessed moment are not fentanyl facing. And so Suboxone and coming off Suboxone are very reasonable realities. So thank you very much. And also to Connie, who I've worked with years ago as well in this context. There's a whole world of people who are affected by opioids and people who work with individuals who are affected by opioids in the Indigenous communities and in those in urban centers and well. So I just want to shout out to all the incredible people who have been doing all this work all these years. Thank you, Carol. Thank you, Connie. Thank you, Ruben. And all the other people that I don't know, but those are the ones that I know. And thank you. And Jennifer, people who travel up and come and do the work. Thank you very much.
Thank you for that, Sharon, and thank you for relaying Claire's question as well. We're getting on past time. I see there's one more question in the chat that I'll relay. Also, I'll point out that Janelle has put the feedback survey in the chat, so please do click on that when you have a moment. But just one last question from Chiara to Subo and Carol. Would you be able to expand on having service providers as participants as opposed to service users? I can imagine there would be challenges to recruit service users / vulnerable populations, but are you aware of any research seeing if challenges identified by providers and users varies or is typically similar? Thank you for your presentation.
Hi there. Oh, thanks for the question. And Carol, feel free to jump in. So for the purposes of this environmental scan, we were only able to focus on service providers. We would have to, you know, it was a short study that was done within a short period of time. As far as we know, there weren't any reports on, you know, the challenges from the service users from RAAM clinics within urban centers. But it would be an interesting project to do, and it would be interesting to see if the feedback is similar.
Thanks, Subo. So we're over time. So I will thank on Janelle's behalf, who I apologize to. She's having difficulties with the platform. I want to thank all of our speakers, Connie and Irene, Maria and Ruben and Carol and Subo. Thank you all very much for your presentations, and thank you to the audience. We're on lunch break now until about 1 o'clock. So please feel free to pop into the break room lounge if you'd like to chat with folks. Please do fill out the survey if you have a chance. And yeah, thank you all very much and hope to see you this afternoon.
Thanks, everyone. Thanks, Sarah.
Thank you.